So welcome back. We should now start. This is our first case. This is a testis in a case which is a 14-year-old, let's say 18, let's say 20, 25, whatever the age is, yes. So this is a sections from the testis in these patients. And I just would like you to see the case as it is now, and don't jump to a diagnosis. I always tell I always tell you guys never to jump for a diagnosis when you see something. So the setup for those who are not used to us, we see the cases together, we try to make suggestions, we give the answer, the best answer in the exam, and then we go through. So I would just show you the sections of the testes first. So this is what you are seeing here on the screen now. I will move to a little bit of a higher power to just show you again another close-up onto this testicular tumor in these young patients, which you are able to see. So you see the first impression. What is the first impression so far? Let me just explore the first impression. Do you think it is definitely neoplastic? Yes or no? So this is the question. Whenever you get a testicular tumor, you should really think, is it neoplastic or non-neoplastic? Because a granulomatous orchitis can sometimes present itself with a mass, and that can come in the exam, okay? All right, so some of you said, yes, we do think it is neoplastic, okay? So which is good, all right? I will just show you a close-up. Right? What is the pattern? Is it a solid tumor? Is it microcystic? Right? So this is the second things that you always have to ask yourself when you are dealing with this testicular tumor. So you think it is a microcystic tumor, or there are micro and intermediate size cysts, or micro and some larger cyst. As you can see, there is a larger cyst here. So it is not all micro cystic tumor. And some of you said, oh, I have a first impression. Okay, what did we say about the first impression? The first impression is the impression which you have to write on the side of your answer sheet. So as soon as someone has formed the first impression, never ignore that first impression and just apply and write it to the side of the answer sheet that you thought, okay, I think this is a germ cell tumor. Then whenever something happened now, you have an insurance policy that you need to protect yourself against. And I am going to explain for you what that insurance policy does mean, right? This is another close-up into that tumor. So I'm just trying to show you the spectrum of it. So we do agree that how is this trauma in between this micro or intermediate size cyst, how does it look like, right? Don't worry, I have a close-up more on other field, but I just wanted to show you the spectrum, and we will have a better resolution here. Yes, here we are, a better resolution of the images. So I am still trying to get an answer. Keep suggesting your answers, okay? These sessions are very interactive, and I just would like you to interact as much as you can, as if you are sitting in the exam. It is the chance here now that we correct the environment and the cloud out of everyone and each one's mind, right? Some of you now suggested this might be an adenomatoid tumor. Okay, so this is one of the suggestions. So we have two suggestions so far. We have the germ cell tumor, and which germ cell tumor, by the way? Some of you said yolk sac or teratoma. So this was the suggestions on the germ cells, and here is another view of that tumor. And so you yes, please come back with the answers, because this is how we will be able to highlight the problems and basically convince ourselves with what we're really seeing and if what we are seeing is the correct things or not, right? Some of you might start doing some imaginations of this structure that I just putting in the middle of the field, right? Which might be what? Yes, so that structure that I just highlighted in the middle of the field, what do you think? What is this? What do we call something like that? Call external bodies, Scheller-Duval, yes, exactly, Scheller-Duval bodies. Is that the right one? Is that how it looks like? Okay, so let's now dissect this case a little bit more to see how things can come wrong in the exam, right? In 2015 exam, a very similar case to this came, and this is not the exam case, but a very similar case came to this. And as you are kind of correct that you felt that there is a microcystic or cystic appearance of this, and then you thought, okay, it might be a yolk sac tumor. That is absolutely fine, yes? So we don't have a problem with that, right? However, whenever you think of a yolk sac tumor, so the colleague of yours who thought it might be then the adenomatoid tumor is also the right methods of thought. And the problem or what will happen in the exam, exactly this. This is a dilemma. This is a dilemma which you will have in the exam. And the reason why, when I started the session, I did tell you clearly that okay, it is a 20-year-old, 25, whatever you want to call it, yes. You didn't take me seriously when I started the sessions with this sentence, didn't you? You did not take me seriously. And the reason why you didn't take me seriously, because you didn't pay attention to two very important things, yes? That the adenomatoid tumor tends to happen in the 25, 30, 35-year-old. However, the pure yolk sac tumor, although it is very rare in the testes because it usually happens as part of a mixed germ cell tumor, right? So what is the problem here? That this is, if you are thinking of this as a yolk sac tumor first, it should have been a child. A pure yolk sac tumor is mostly and almost always in a child, okay? So if it is part of a mixed germ cell tumor, it's a different story, right? But what we saw here is we didn't see seminoma, we did not really see embryonal, we didn't see the ectodermal or the neuronal tissue or cartilage or anything to highlight this, okay? Don't assume, oh, there might be in other sections in the testes, yes? Okay, no, you don't assume in the exam, okay? What you do in the exam, you report what's in front of you, right? Either you like it or not, you only report what's in front of you. You don't tell me, oh, there might be a small piece of cartilage in another section that I'm not looking at. That debate, you do it with your friends outside the exam. But in the exam, you stick to your slides and you stick to what you really have to see. And it is true that the dilemma in this particular case between the yolk sac tumor and it is between the adenomatoid tumor. We have not resolved the diagnosis yet, okay, for the people who are assuming now that this is the yolk sac, okay? We have not resolved the case yet, right? You tell me now, you tell me what these cells are doing, okay? These are vacuolated cells. And in actual fact, they are even forming what you call it as signet ring cells, right? If this signet ring that you are seeing in the field now, right? Let me just mark it so you don't tell me I didn't see it, right? So this signet ring cells, which you are seeing here, if this is a yolk sac, if that's what the yolk sac do, they give you a signet ring cells? No, they don't, right? So this is number one problems which you do have into that case, that you are interpreting what is happening, that you are interpreting basically the architecture, and you completely and utterly forgetting about the cells, right? So what you need to do then to start reading the cells, and no one has told me I want to read these cells more. Yes, I showed you that false, and I gave you false reassurance that this is the Schiller-Duval body. However, that's not a vessels in the middle. I'm so sorry, this is not a vessel, okay? And therefore, your interpretation was wrong, okay? Your interpretation for this was wrong. And what you ignored in the background, all these vacuolated cells, and the signet ring appearance of the cells, which are the cells which we should see them in the adenomatoid tumor. So it is adenomatoid tumor. And this is this is how you can go wrong in the exam with cases, that you have been trained hard on the yolk sac morphology, and you forgot two facts. The first fact is that majority of the yolk sac tumor, if it's going to be pure, it happens in children. And the second part that you also missed into this tumor, your interpretation with what is Schiller-Duval body could be. And that means from these points onward that you really need to train your eye properly on what Schiller-Duval body looks like, okay? The second thing is that you need to train your eye to detect these signet ring cells and vacuolated cells, okay? And I can show you how vacuolated it is. It's even indenting the nucleus, like what we see in the lipoblast and things, yes? So you can see the vacuolation as well in another cells here. This vacuolation inside the cells is not a feature that we see into this adenoma, into this yolk sac tumor, and therefore you don't. And you don't have the other sheets, which ideally sometimes we see them with the polygonal cells of the yolk sac. Sometimes you will find these sheets within, and but the exam can be so cruel. And my advice to you, and this is exactly what I would have done in the exam, right? Even if you are 100% sure that this is going to be one of the others, yolk sac or adenomatoid, don't forget the point of the H first to highlight this. And don't forget that pure yolk sac tumor is really, really rare. And if it's happening, it's going to happen mainly in children. So if you have a 25-year-old, and I'm telling you this is a pure yolk sac, then so answering the questions which has been raised in the chat room, yes, then you would want it to do the extra blocks and all of these sort of things which you wanted to see, because based on the fact that pure yolk sac tumor is extremely, extremely and utterly rare into that age. However, what I would wanted when you're faced with a case like this and you're not sure because you are imagining Schiller-Duval bodies, whenever you start looking, you can start imagining them. There's another one, maybe. There's another one here, maybe. It is because of this lacy-like appearance of the thin trabeculae that intermingling with each other, you can start building this Schiller-Duval body forever. But is it easy? Is it that easy to see Schiller-Duval body really in this type of tumor? Do you really see it that easy, that everywhere you will look, you will imagine one, and that's it, that's it, that's it, that's it? No, it is not. Right? So go back to the Schiller-Duval, study it very well. But in continuation, what I would say, okay, favor what you think you wanted to favor, but say my differential diagnosis in this case is this. And then try to correlate it with whatever you want to correlate for the age and the fact that that doesn't occur on its own and all these sort of things. But then give them the differential diagnosis for each other, and please, please just do the immuno. Now, what I'm teaching or what I'm advising, let's forget about the word teaching because I don't know anymore. I left the exam years and years ago, so you guys know better than me. But what I am teaching for you guys here is the skill. The skill that you need to acquire and adapt for the exam. And this is what you need to remember, that a case like this can ruin your career, your exam, and make you repeat the exam because of you being overconfident in your diagnosis. And even if I am to come across it, I would say, okay, adenomatoid tumor, the differential diagnosis in this case is yolk-sac tumor, however, less likely because of the reasons which I mentioned, that it pure is rare and things, and these vacuolated cells and the signet ring appearance cells doesn't really happen with the yolk-sac. I didn't see the polygonal cells which is normally present in the yolk-sac. I didn't see other component. And then I say my immunohistochemistry, then I will do, of course, my cytokeratin, my calretin, and to confirm my diagnosis. And I can also include the yolk-sac marker sulfur or alpha-fetoprotein or whatever you want to include. And anyway, what I am trying to tell you here, even when you are about to raise this differential diagnosis, you have to favor something. Even if you favor the wrong answer, you will still score 2 out of 3.5 because your right answer is in your differential diagnosis. And then the examiner will ask himself or herself and will say, after doing the immuno, would this person have reached the right diagnosis, yes or no? And then if the answer is yes, then they will give you the 2, which is sometimes borderline fail or borderline pass, depending on the impression. But if you favor the wrong one, you will go for the 2. But if you favor the right one, then you will go for the 3.5 by giving this answer. So this is, and of course you have to say adenomatoid tumor, mesothelial origins and all, and it is classified as tumor because we don't know the behavior fully. We don't understand the behavior fully of this tumor. But what it is, you can write whatever you like after that, but you have to tell me if you favor something, why? And if you don't favor something, why? And where do I write it? Where do I tend to write something like this? I write it as soon as in the diagnosis section, right? So we said the first section is your microscopy description. The second section is your diagnosis and differential diagnosis. Your third section is additional work. And your fourth sections, if you remember, for those who has followed us from before, will be your clinical pathological and additional points which you want to add for prognostication, for treatment, for discussion in specialist meeting, all of those points that I mentioned on and on again before in my previous sessions. So in the second section of your answer, as soon as you put my differential diagnosis is, you have to tell me why you favor the diagnosis, and you have to tell me why it is your differential, for example, yolk-sac is less likely because, and then you say because of this and this and this. So, but you still would like to confirm with the immunohistochemistry. Exam is not about playing clever. It is about playing safe and be confident and knowing the pitfalls and knowing how you will get yourself out of it. Is that clear in the mind of everyone? Yeah, yes. Any questions before I move on to the next case? Okay, very good. Thank you very much. So we will move now to the case, the second case. So this was the easiest case of the day, right? So this was the easy case of the day. I will skip this and I'll show you that one. This is a punch from a patch in the back of a middle-aged woman, right? Now, it is, you have a questions from Dr. Mariam Jamil. She is asking, what if I don't give a differential diagnosis and I'm very confident about my diagnosis? That's absolutely fine. However, we said that there are situations where there is a must that you have to give a differential diagnosis, and this will include the small round blue cells, even if you're 100% sure a diagnosis of rhabdomyosarcoma in a short surgical case, you still have to tell me what is the differential diagnosis as a malignant peripheral nerve sheath or dedifferentiated lipo with rhabdomyosarcomatous differentiation and others, and leiomyosarc, of course, and all the others. What I'm trying to say, it depends on the situation. Okay, if you have a granular cell tumor, you're not going to give me a differential diagnosis. You will tell me this is a granular cell tumor. But we apply the differential diagnosis for what you think it is. But once you put the differential diagnosis, you have to give me the preferred diagnosis or your favorite diagnosis is. My differential diagnosis is. So once you put a differential diagnosis, you have to say in between brackets, what's your favorite diagnosis? Next to the favorite diagnosis. You cannot leave it to the examiner to pick one, right? So let's move to this case, middle-aged. There is a skin patch on the back, okay? No previous history of anything, right? So this is a section from the skin, okay? And I will just give you an intermediate power here to let you think about it a little bit. And you never jump for a diagnosis. Okay, so as this is what we do. We think together of the case and we build it together. Yes, in the exam you have 2 minutes, but I give you the 2 minutes to think about the case. Okay. Right, so you always, your questions with any slides will be almost always, are we dealing with an inflammatory process or are we dealing with a kind of neoplastic process? You always have to put this in mind first, right? Because if you don't put this in mind first, you will always have problems when you come to interpreting cases like this. Okay, so we need to, you see, this is the what I don't want you to answer. Yes, I want you to adapt to the English style, right? You see, the English style is, what is the pattern? What is the problem, right? That is the English style. And as Dr. Amal Musa correctly said, this is the pattern, and this is what you wanted to put in the first line, actually, of your diagnosis as well. You see, there is an element of spongiosis and there is an exocytosis, right? we don't play a clever game in the exam, right? And this is when people will go wrong, right? Because what will happen exactly in the exam, you will say mycosis fungoides. And then what do you think the examiner will do with that answer? What do you think? The question is, every time this person see a perivascular lymphocytic infiltrate with lymphocyte exocytosis, then this person will call the case as mycosis fungoides, right? So what should we do with this person, right? So this is what will happen. You can't do that, right? And this is the wrong answer. What we are trying to do here is to make you adapt to the way that we will report it. Since when? Since when we do see a lymphocyte exocytosis, and then all of a sudden you jump for a diagnosis of mycosis fungoides. Since when you do something like this? Since when? Would you, if you practice in whatever country you work, is based on the fact that you diagnose the mycosis fungoides on morphology, then please take that away and don't bring it with you to the exam, right? You are correct that you can tell me there are with atypical lymphocytes. So if you want to tell me epidermotropism with atypical lymphocytes, you are absolutely fine, right? So lymphoproliferative disorder cannot be excluded. My differential diagnosis is mycosis fungoides, okay? Or whatever you wanted to put after that, but without having the right immunoprofile into this infiltrate, you cannot commit to the diagnosis, right? But you can tell me how I will build the answer, right? So I have this biopsy showing superficial inflammatory cell infiltrate, right? Perivascular infiltrate with lymphocyte exocytosis or epidermotropism, whatever you want to call it. It's also showing you these features, which we call it the beading, which is why some people felt it might be a lichen. But if I go back to the first low power slides, where is it? Where is the band-like inflammation here? There isn't. The inflammation is perivascular. Let's just start the story again from the beginning, from the very far beginning, right? This is a superficial perivascular inflammation and epidermotropism or lymphocyte exocytosis, as you correctly said. As soon as you start to see these white lines between the cells in the epidermis, because some of you were asking, where is that spongiosis? I don't see it. No, there is. And the problem is, if you do have a lymphocyte exocytosis with the spongiosis, there is definitely a lot of white areas between the cells, okay, between the keratinocytes. So, and you can see the borders become very exaggerated now. There is a spongiosis. So the problem, or the real problem for the dermatologist, that when they deal with the subacute or acute spongiotic dermatitis, which can be present into a similar events like this. So you can see spongiosis with marked exocytosis in the acute spongiotic pattern of inflammation. There is nothing to stop this pattern from producing that. And this is clinically, the dermatologist, if they are worried, they cannot, and they will always put for you the two differential diagnoses against each other, like a contact dermatitis or acute dermatitis, acute spongiotic dermatitis versus mycosis. because this is where it happens, even against early psoriasis sometimes in some cases. But what it is that the pattern is important, and you need to tell me why. Did you define it because you just saw that there is abnormal lymphoid cells? Okay, and what is your definition of abnormal? All right, so for those who told me that they considered the lymphocytes abnormal, tell me, why did you consider these lymphocytes abnormal? Okay, based on what? Right, so based on what did you consider this abnormal? Don't be shy. I am here to learn from you, and we are here to share knowledge, right? Okay, so there is a halo, right? So the lymphocytes can have a halo in a spongiotic dermatitis. However, it is not going to be as florid as this, right? The lymphocytes will mold when they go into the keratinocytes, because they are trying to be squeezed between the melanocytes. Yes, so they are trying to get themselves squeezed, like this fellow, for example. Can you see? Let me just highlight for you some. So, for example, what you will see that this lymphocyte is trying to change its shape to be able to accommodate it. This little one here is trying to accommodate its shape. That one is trying to become a little bit elongated to accommodate its shape. This is what the normal lymphocytes will try to do in order to squeeze themselves into this, in between the epithelium, between the keratinocytes. However, some of them, spongiotic dermatitis, might have the halo, but not all of them. You see, the lymphocytes here are trying to form these halos. As you can see them, they are scattered all through. So what they are trying to do, they are trying to find themselves a space in between. I will not judge the racinoid nucleus. I'm sorry. I just told you, Dr. Mariam, that it is the keratinocyte naturally. In spongiotic dermatitis, they go and they tend to squeeze themselves, and they will change the shape, they will mold, they will become racinoid. They can become. So next time you have a spongiotic dermatitis case, if you don't believe me, look into the infiltrations of these cells, and you will understand that wide and clear, right? So this is just to highlight these points and make it clear. Now, the other features which we talked about, there was one features which we did not really find here, which was the abscess. Sometimes you get an abscess, of course, but sometimes you get this beading where the lymphocytes start to arrange themselves like a row. And this is, you tend to see this, you can see it with the interface dermatitis. You don't tend to see it that frequent with the spongiotic dermatitis. So if you start to see it quite frequent, then you should be able to also help you to reach the diagnosis into that spectrum. However, so the way that I will answer a case like this, I will say, this is a superficial perivascular with a spongiotic pattern and atypical lymphoid cells, right? My differential diagnosis is between mycosis fungoides and acute or / subacute spongiotic dermatitis, whatever you wish. And then, but I am favoring this for mycosis fungoides. However, I will need to do the immunoconfirmatory immunohistochemistry for this. And you are correct that you need to get into the panel. So you need to do all the CDs, you know, like the CDT cells, like the CD2, CD3, CD5, CD7, CD8, and CD4, and you also need to do the CD20 and to see the B cells in the background, and the CD30, of course, if there is a large cell transformation, right? So yes, I said CD22. CD20, yes, this is what I meant, that you will have to do it because you need to be able to see this, which is the dominant population, and you need to see which cells is going up. It is not about the mixed population, okay? Because it is about which one is going to go up, right? So in this particular case, this was the CD2, okay? And this is the CD3, right? So I'm just showing them to you quickly, and this is the CD4. This is your CD5. So when I show them to you today, you will not forget that panel now. And that's the CD7. Okay. CD8. CD20. And CD30. Okay. So what do you think? I showed you. Let me just go back to the CD20. This is the CD20. And this is the CD8. And this is your CD4, right? So what I'm trying to tell you here, right? Especially for the people who don't really see routine mycosis fungoides. So you will be able now to, what is, yes, so you see, now people are doubting themselves, isn't it? You see, because the immunohistochemistry for mycosis fungoides can be very tricky and can be very difficult. We agree? Right? So it can be really tricky and can be really, really difficult. And what I want to show you now, you will have to agree that they look more or less all the kind of the same in somehow, especially the CD4, the CD5, CD, here they are. I'm just showing them to you again. Do you see that? This is our CD8 and this is our CD20. Okay, for those who were pro fan of the mixed population and thinks, yes. So here to prove to you that there are some CD20 cells here. So the CD7, okay, someone want to see the CD7 again? I will show you the CD7 again. Here it is. What do you think? Okay, how do you judge it? Yes, so you see the problem here now, if the mycosis fungoides is to come in a long case with the immunohistochemistry like this, which is usually like this, then you may now start doubting yourself. But what I'm trying to teach you here, or to remind you, that you need really to compare. It is a comparison process. This is your CD4, right? So this is your CD4. And then this is your CD7 in comparison, the same field. I will compare the same field now, okay? So I will compare the so definitely there is a decrease in the expression of the CD7, right? And if I compare it, which is a more important thing, to the CD8, so there is still a relative decrease in the expression of the CD8 in comparison to the CD4. So this is your CD8, and I will go again to the CD4. And this is your CD4 here. So definitely they cannot be compared. So it is not intensity alone, it is the number of cells here, right? No, it's not intensity. What I'm trying to tell you, that the exocytosis which is happening in the mycosis fungoides, it happens not only with the neoplastic T cells, but also within those you will see a normal T cell. And this is what this is the point. The point is that the immunohistochemistry is not about positive or negative, okay? It is about this ratio, as some of you said, which one is more, right? So it is here, the CD4 is more, the CD7 is nearly lost in these particular cells. It's preserved in the normal cells, which went up, because together with the crowd, some cells are going up, but they are taking with them some other cells. Naturally speaking, you shouldn't get the CD30 positivity unless if you have some prominent, sometimes fibroblastic proliferations within the, histiocytic proliferation in the inflammatory cells. You can get sometimes some CD30, which is not neoplastic, but just remember that pitfall. But of course, the diagnosis of the CD30 will rely on the fact that you see anaplastic-like cells in the superficial perivascular infiltrate. And this is where, of course, for those who are not very experienced with lymphoma, this is where you will be looking for the CD30. So your CD30, you're looking into the superficial perivascular infiltrate, and you have to look for it when you have big cells, like the ALK1 T-cell lymphoma, anaplastic T-cell lymphoma cells, which will have a lot of cytoplasm, but it looks very atypical as well, and dark with a prominent nucleoli, and everything will stand on it. Yes. So in here you can see the CD30 is negative. You can again remember, this is not any near to your T cell population. This is your CD20, and your CD8 here. Just imprint this image, and I will take it to your CD4, which is here, and the CD4 is definitely nearly double the number. And this is that relative things. This is how you should read it. And you shouldn't say, yes, in reality, it is absent. And in reality, again, if you wanted to see the point, and this is another point that you can add to the argument, but I don't want to make it difficult for you, because then we will be taking it to another level. But if I ask you, okay, with the simple things here, what can you see that there is a little bit of double intensity of staining? There are some cells which are a little bit paler, and some cells are a little bit darker. They are really dark cells. Okay, while when we go to your CD7, you don't really have that phenomena that we saw. It is more okay. And when we go here into our CD8, it is not really this phenomena that we're seeing. It's not like as we saw it in the other one, that you have a distinct population. And therefore you need to learn how you read it, because the main problem, so the first problem is, if you jump for diagnosis, and that's in return to the answer when I should say you should favor. Yes, if you think that you saw the beading, and you think that a lot of halos, and maybe you see abscess, maybe you see that it looks atypical, then that's fine, you should favor it. But don't forget that there will be the cases. There will be the cases which will bite you back in your neck, and you don't want that to happen on the day of the exam. The other things is that if you have the brave heart to say it, you say subject to confirmation with immunohistochemistry. If you are coming from a country to set the exam that they don't do immunohistochemistry for mycosis fungoides, this is your practice locally, but you don't bring that practice to the exam, right? I am maybe cruel and rude, but this is the only way for you guys to be able to safely pass through and sail through the exam. For me to highlight these points and be clear and all clear about it. Okay, is that clear for everyone? Right, so I hope that the case is fine. Mycosis fungoides with differential spongiotic, acute spongiotic dermatitis, and then we basically subject to confirmatory immunohistochemistry, and then we are happy and living happily ever after. Right? Okay, excellent. Now we go to another case, which is a parotid tumor in a middle-aged male patient. So the two did superficial parotidectomy. This is a section from the parotid glands. Okay, so now you need to tell me, when you get struck by something like this in the exam, okay, would you put your hand on heart? Yes or no? Right? Will you say you hate the day that you entered the exam? Yes or no? This is my questions. Would you be hating this? Yes. Right? This is one of the most difficult areas in the head and neck pathology. Right? And if you think it's easy, then I can guarantee you from now that you will be failing the case. Yes? So this is a very difficult case. So this is parotid gland. So first of all, what comes, we stay on the low power a lot in these sessions, because my intentions as well is to teach you about the low power importance. I stay on the low power and till I get bored of it. And after I get bored, and then I move on, right? So the first minute, you have to focus. So the first thing says that one of the possibilities, as you correctly said, it might be lymph node, intraparotid nodes, because yes, we can have intraparotid nodes, right? I want some more suggestions. What do you see as well inside this node? What is that space that you are seeing? Is that blood vessel? Or this might be a cystic space? What are that white things that you are seeing? It looks, yes, so this can be coming under lympho epithelial cysts of some sort, yes? So this is another sort that you have to address, okay? Or a lymphoid cystic tumor, right? So we have lymphoid cystic tumor, we have another, which is like adenolymphoma, like the Whartons, can be cystic. Can it be lymphoid-rich Whartons, right? So you can, okay. It can be lobulated tumor, yes. So this is another possibility it can. But you're only thinking of tumor. What is it that you are not thinking of as well? We thought of lymphoepithelial cyst, but what else? What else can it be? Right? You're still thinking of tumors here. What else can it be? Right? Just think with me, because this is the way that we think, so we don't forget about it. Okay? Not really particularly infection, and not thymus, because that's not midline, although there are some reported cases, I know. Okay, some of you said might be lymphangioma, okay? Cyanidinitis, yes, absolutely, right? So you can get the cases of lymphocytic cyanidinitis, which can be looking something like this, right? So this is another thing, but let's put also lymphoma, right? So let's not forget lymphoma, because it still can be lymphoma. So you see, what I'm trying to tell you, that this is how difficult these cases can be, and all of these things have to come, but has to come very systematic, right? So we thought of the architecture, nodularity, and we thought of all these possibilities. Now we have lymphoepithelial cyst and Whartons and chronic sialoadenitis and or lymphocytic sialoadenitis, and you have, of course, the lymphoepithelial cyst, and all of those coming into the equation. Right. Let me now close up on the field here a little bit and try to show you what we are looking at here. Okay, so for the phonetics of the lymph node, can we take the lymph node out of the equation? Yes or no? Yes. Okay, so we can take the lymph node out of the equation, right? Because we can see salivary gland tissue. Yes, you can see sometimes inclusion of salivary gland tissue inside the lymph node. So don't forget that. But you need to then to see the capsule, and you need to see the architecture of the node. But also what you're seeing here is acini and ducts. So you have the full blown salivary gland tissue. So there is a salivary gland tissue admixed with lymphoid tissue, right? Out of the tumors that it might have epithelial and lymphoid component, if you think of a tumor, or okay, so this is one part of the spectrum now. The other part is you have some tumors which can have acini and very lymphoid rich population like Wharton's, like acinic cell, right? So you don't forget that acinic cell, there are variants of it which can have exactly this, can have the acini and can have what looks like a Wharton's tumor present in the like Wharton-like background in the background, like a very lymphoid rich. And if you don't believe me, just when we finish, read it in the textbook and they will tell you. Now, some of you said sialoadenitis versus lymphoproliferative disorder. Okay, so that is another thing to highlight. The other one, which is the lymphoepithelial carcinoma, right? So this is another thing to think about, lymphoepithelial carcinoma, right? Which can happen in the salivary gland because it can be lymphoid-rich tissue. So lymphoepithelial carcinoma can happen. So now what we are trying to do, and this is what we have to do, is that you need to escape from the fact that you diagnose. It is not, if you're wishing, if you are new to us, let me just repeat this sentence again. If you are new to us and you think if you come up with the diagnosis, you are a clever person, I will tell you, you will fail the exam, right? I'm telling you now, right? Because you should tell me my differential diagnosis is, especially in a case like this. We don't diagnose these cases by morphology alone, right? With all my respect to your experience, with all my respect to your eye, we don't diagnose these cases unless if we do a further work, because the differentiation between these lymphoid-rich lesions is one of the most difficult areas in the salivary gland pathology, as we've agreed at the beginning of reviewing this case, right? So let me carry on and show you what do we see into this, and then you will see more pictures and more pictures here, yes? Because we have not finished with the case yet, yes? So we haven't finished. So I'm just trying to get you into the pictures of the higher power, right? So we have a higher power, okay? Right, who said that? Who said that we cannot put sialoadenitis versus lymphoma? What is the main problem of the sialoadenitis? Yes, okay, yes, I know you're asking, but who, you see, no, you can, providing that you will favor something, right? But you are telling me what the problem is that you are facing, okay? These are salivary gland tissue admixed with inflammatory cells, as you can see here, okay? And I am just streaming through it to show you all the spectrum. Okay, and I showed one of the important things to highlight, especially if you are thinking of actinic cell, is in the actinic cell, you don't tend to see ducts with alveoli like this, with acini, sorry, not alveoli. Here, can you see that? Can you see this appearance that I just marked? You don't see that, right? So if you were thinking, can it be actinic or not? Because you can see a lot of acini, although yes, we know they can be normal, but you don't tend to see this duct with acini, so we can take that off. Now, you need to also be able to understand the morphology of the different ductal epithelium in the parotid gland. So if you're not familiar with it, because they are intercalating duct and there is the larger ducts, so you need to be able to appreciate that some of the ductal epithelium can look like the Whartons, but don't over-interpret it. So you still need to be able to define the papillary architecture, the other features of Whartons, because of some people were suggesting Whartons to start with, yes? So this is another thing. The other point of Whartons that it tends to happen in elderly and smoker, but if I told you this is a middle-aged person, which is a little bit unlikely. Now, for the clever people who do a lot of head and neck, they felt that they probably saw epithelium eating into the ductal epithelium. And this is why they kind of tried to lean a little bit more towards the lymphoma, which is, I agree, it's a feature that it is worth noting. That in a field like here, what you are able to see, you are able to see the lymphoid infiltrate. It's not only infiltrating into the epithelium, but it is like the moth-eaten appearance of this, right? So this is like a lymphoepithelial lesion, but you can, and you are absolutely correct, that you can see a phenomena like this in the chronic sialoadenitis. There is nothing to stop it from being there. So lymphoepithelial lesion alone is not a thing that I will use as a diagnostic features alone. It will make me think more now over lymphoma, but I will still have a doubt in the back of my mind, and without doing the immunohistochemistry, it is nearly impossible to be able to judge this as MALT, but in the exam, you will need to see this. The things is that you need to see that first is, this is a diffuse infiltrate. And the diffuse infiltrate here is not forming lymphoid follicles. We probably agree on this. And I am just trying to show you this lymphoepithelial lesion in close-up here. So I will just show it to you in close-up so you believe me. What it is that people didn't, in the heat of the case and in the heat of the fear of the case in the exam, that a case like this might come in the exam, what you did forget to assess is two things, right? Whenever we deal with a lymphoid infiltrate, we have to apply the rules. And the rules does say clearly that you need to look into the pattern of distribution. Is it diffuse or is it nodular? Okay, so you can work it up. The second thing is that you need then to look into the morphology of the cells to tell me if these are small cell size, intermediate lymphocytes, or large lymphocytes, okay? So for the people who has been devoting themselves very hard to the fact that these are marked lymphoma from the first look, what are these cells that I'm trying to show you in the middle of the field? Okay, what do they stand for, and why we are getting cells like this in the middle of the field? Okay, so let me stand here. The thing is, one of the things when you also think of a lymphoma, that you need to think there is 3 lymphoma that can happen in that can happen in the salivary glands. Yes, the first one and the most common is the mild lymphoma. The second one is follicular lymphoma. The third one is the high-grade diffuse large B-cell lymphoma, right? So these are the 3 which can happen into this. Extranodal Hodgkin lymphoma is extremely rare outside the context of mediastinum and lymph node. It is, and the spleen, I mean lymphoid tissue, it is extremely rare to occur, right? And the reason why some people see Hodgkin lymphoma in salivary gland, because they see it in the intra-pouted nodes, not in the intra-pouted tissue, okay? So what we are seeing here is an intra-parotid tissue tumor. Now, you have a lot of large cells, as you probably started to realize here into the field, okay? And then for those people who were a minute ago trying to advocate for the fact that this is going to be a mild lymphoma, I think they disappeared now, right? So some people now are still, they are revising their words because they are saying, okay, yes, I probably should have paid attention to the type of cells before I go any further, right? And this is what I want you to do, right? I want you to understand which, even if you think now it's going to be lymphoma, am I dealing with an immunoblast proliferation of blast-like cells? Okay, let's put it like a blast-like cells, or are they small? Are they intermediate size? Do I have a reference cell that I can compare the size to? If you don't have, then find the poor red blood cells and try to compare the size of the lymphocytes into the equation. And then you try to figure out the situation. Now, for the clever people as well, and so now you understand this, yes? This, you can tell me that I saw enough of lymphoepithelial lesion, yes? So yes, we might be dealing with a lymphoma or a lymphoproliferative disorder, such as the lymphomas which I named, but this is diffuse pattern of inflammation. So your follicular is out. We are left with the MALT, and we are left with the diffuse large B. But in all the fields which I have just shown you and I've gone through, there isn't a lot of what you call them tangible the sky appearance of the tangible body macrophages that you see them with the diffuse large. And we didn't really see as well a lot of mitotic activity or really ugly cells, but we saw some larger populations of cells which we are not sure. So far, if you are to argue the case at this level, and you saw a lot of lymphoproliferative lesion, like here in this field, every group in this field, every epithelial group has been eaten up by your lymphoid cells. So I agree that this is most likely is lymphoma, right? So I would say that although the differential diagnosis here is between, this is a lymphoid-rich infiltrate with lymphoepithelial lesion inside the parotid gland. So this is my conclusion line. What I am saying now, this is my conclusion line. And then I say lymphoepithelial. So my differential diagnosis is lymphoproliferative disorder, which is non-Hodgkin B-cell lymphoma with diffuse pattern. Okay, right? So I can say something like this, or such and then in between brackets, such as mild lymphoma, for example, and lymphocytic cellular-adenitis, right? And I would like to do the but I favor this, you see? So in between brackets, remember this magic word. The magic word, favor diagnosis. But you have to put it in between brackets. But then lymphocytic cellular-adenitis, because having been in the head and neck fields, as some of you know that I'm a head and neck mainly pathologist, and then I have seen a lot of pitfalls into this area, especially with lymphoepithelial lesion, right? Yes, because the T cells is extremely rare, right? But what you can say, non-Hodgkin lymphoma, how about that, right? So you can tell me this is a non-Hodgkin lymphoma, right? And without immuno, this is as far as you should go if you want to suggest mild, because this is the most common, and you realize that this is a predominantly small cell, and predominantly the moth-eaten appearance are composed of small cells, and that means that the background might be immunoblasts, and that means that we didn't see the star sky appearance, we didn't see mitosis and apoptosis, which comes with the diffuse large. And therefore, in the diffuse large, unless if it is a lymphocyte-rich, histiocyte-rich, T-cell-rich, it will not come here. But this is not common here to occur in the parotid. So don't complicate this story. The story is very simple. It is between mild, diffuse large, and follicular lymphoma. If it is not forming the follicles, then it is between mild and the diffuse large. If you think that there is a lot of small cells in the background and it is diffuse, then it is mild. It is as simple as that. But yes, you will still have to do the immuno. I am not saying a definite diagnosis here. I am saying this is a lymphoid rich, okay, tumor with lymphoepithelial lesion, okay? And I am favoring this to be a non-Hodgkin lymphoma, in between brackets, mostly mild lymphoma, right? However, differential diagnosis will include cellular-adenitis and other types of lymphoma, such as diffuse pattern of follicular lymphoma, diffuse variants, and the diffuse large B, okay? Never say never. But T-cell lymphoma is extremely rare to happen in the parotid glands. So don't go with the extreme rare diagnosis because you read it once in a paper, you read it once, blah, blah, blah. That's not the right attitude. The right attitude is what is common is common. Yes? So you are saying non-Hodgkin lymphoma, favoring this to be mild because this is the most common lymphoma encountered in salivary glands. This is what you write. This is what you write, what I'm saying. Yes, because this is the most commonly encountered lymphoma in the salivary glands with this pattern and this type of cells, right? So it is not an argument between B and T cells, right? So forget that argument. That argument for the lymph node, that's fine. For metastasis somewhere, that's absolutely fine in liver, spleen. But here in the bowel glands, every rules apply. As for those who follow the soft tissue teaching, the rules will differ from where we look into the spindle cell, between breast, between uterus, between retroperitoneal space. The rules are different. The differential diagnosis is different. Right? And let's not forget, the exam is a context of knowledge, and your knowledge about lymphoma in salivary gland will be tested here, right? And if you don't know that the multiple lymphoma is the most common, it's your fault, right? If you start to open the gate for all the other lymphomas, then you are opening the answers and you're opening your panel. You don't want to do that, right? So you don't want to do this. So you can say, if you want to stop by non-Hodgkin lymphoma, that's fine. Yes, but if you want to say, I'm favoring this based on the pattern, the size of cells to be marked lymphoma, then that's absolutely fine as well. Okay, there is no wrong or right answers. Yes, but there is more specification answer, how far you want to take it. Okay, but in keeping with favoring this to be multiple lymphoma, okay, as this is the most common lymphoma with this pattern in major salivary gland tissue. So you can say that, right? And this is what I want you to do. You don't write your diagnosis and you run away. You write your diagnosis and you tell me exactly why did you come to this? Because of the pattern, because of the size of the cells, because of the presence of this lymphoepithelial, frequent lymphoepithelial lesion, then I'm happy. And then that's absolutely fine. And then we are happy with this. And then we reach into this diagnosis. In any panel, we are nearly finishing. It's just I'm aware of the fact that we passed the time. But remember, in any panel that you will put, okay, that we will have this cytokeratin to show the lymphoepithelial lesion and how it has been broken up. Now, progressing to diffuse large B cell, again, Dr. Marwa, you are going into a very extreme areas in the pathology, and the FRCPath is teaching the basic level. It's not an advanced exam. This is not your PhD. Okay, so stick to the basics, right? And when you see diffuse large B cells, you see the transformation, the area become ugly, necrotic, apoptotic, with a lot of mitosis. Go back and look into that transformation if it happened with the CLL, okay? Or if you have any lymphoblastic transformation, you will see what I mean. You will see that it becomes very ugly and it will be really that. Okay, that's your grade BCL6 for the people who like to call this diffuse large B cell lymphoma. They are out of the context. This is your CD3 to confirm for those who didn't want to push for the B cell lymphoma. Okay. This is your CD5 for those who would like to exclude the CLL. Okay, and this is the CD10 to confirm that this is not a lymphoid follicular pattern. That's your CD20. Okay, and usually in majority of the background, this is your CD23, and this is your CD79A. Okay, so now the majority of this, don't forget that the majority of these cells, what you want to do, if I give you that pattern, you wanted to get me in the exam, and this will be my final points, that I know it's only in 40% of cases. So yes, you can mention it, but it's only in 40% of cases, and there is a lot of cross match with the CD43, okay? But what you wanted to do, if I give you a pattern like this, you wanted, of course, to do the Chi67, yes, proliferation index, so that will be very important to do. And your second things which you would like to do as well will be BCL2. You don't see the BCL2 here, yes, which you would wanted to have it as well in your panel. So you can, if this was a long case, you still wanted to suggest this. Now, the majority of the cells which will be in the background of lymphocytic sialoadenitis, usually it's a mixed population, but a little bit slightly predominated by the CD3. And correct me if I'm wrong, but I think as far as I remember, this is what it is. You get a mixed population, okay, which with some more of a CD3, because it is the nature of the beast. But well, this is just to highlight that. But you just based on that alone now, it is. I hope that this is very clear, and I hope that this you need to resolve the differential diagnosis. If you want to expand on the differential diagnosis, you can, but you increase the time of writing. And this is the problem. You only have 8 minutes. So your differential diagnosis has to be concise, because once you raise the differential diagnosis, you have to make the work with your immunohistochemistry. You have to make the work which you will exclude this, to tell the examiner how you are going to work it out. You've been playing clever and throwing a differential diagnosis to me, okay? Then tell me what you wanted to do now to resolve this, okay? So no, you don't do, if you saw a lot of lymphoepithelial lesion, this has to raise the lymphoma, and it has to be endiolymphoma. You have to through the multi-lymphoma panel. You have no escape, okay? But if you try to tell me the panel of T cells and B cells and let the examiner pick which one you will go for, I will deduct mark. As an examiner, I will say this is inappropriate panel, so I will not make you score any point above 2.5, because I will make a big cross against your panel. Okay, so this is just to highlight that. Your panel has to be directed toward resolving your differential diagnosis which you have raised. If you're talking MALT, then you give me the panel of MALT. You don't give me the entire panel of the Hodgkin, non-Hodgkin, T-cell lymphomas and everything in the panel. You will score nothing. You will only score what you put in your conclusion, and that's it. If it is right, it's right. If it is wrong, you will get 2. Okay, and that's it. Borderline fail. So it's not going to don't play clever in the exam. It doesn't work that way, right? So the panel has to be very specific. Okay, so I hope that this does answer most of your questions, guys. And I hope that these cases were of interest. And it's just for those who did not attend with us before, you know how we do these sessions now. And yes, this will be uploaded with the other FRCPath lectures. So you will be able to, for those who would like to catch up with this, yes, they will be able to see. So I will have to leave you now in peace.